All right, welcome everybody. Good evening. Thank you for taking the time to come on. Tonight we have Dr. Ben Miraglia. He is a leader in pediatric airway development and adult expansion. So welcome, Dr. Miraglia. Thank you for coming on tonight.
Oh, it's my pleasure. Thanks for having me.
Yeah, we're so excited to have you on here. I can't wait to get this episode on my podcast all live for, my listeners. But let's just start. If you want to tell us a bit about your 17-year airway journey.
Oh, yeah. So I was a restorative dentist first. And so I spent a decade doing crown and bridge and implant reconstructive dentistry, mostly in the fixed format, very little removable dentistry. And about a decade into that, I just started taking some classes out of interest because we were referring children for orthodontics and at 12 and getting braces. And one thing leads to another, and next thing you know, you're just interested, you're learning a little, you take a couple of courses, then you realize you stumble upon, well, it turns out there's an entire field of expansive orthodontics out there. And so one class leads to another class. And now here I am in my 27th year in dentistry, but my 17th year of doing kind of growth and development, early expansive orthodontics for children. And that has really progressed to be a comprehensive form of treatment for children through adults. But I didn't know it all 17 years ago. It was the beginning of kind of a journey to where I am now, which I feel like I know more, of course, than 17 years ago, but I don't feel like I know all of it yet. So I'm still learning, but certainly the orofacial myofunctional therapy is a very big component of it. And I know that's going to be part of our conversation tonight.
Yes, absolutely. And I know about that rabbit hole. Once you get in, you can't really get out. You just keep going deeper, deeper, and deeper, and you love every second of it. And just when you think you know everything, you learn that you do not know everything. So tell us about why you created the Airway Health Solutions mini residency and what your goals were in doing so.
Sure. So over time, as the years were going by, we're learning more and then doing more. And it turns out we begin to treat children as a collaborative care model. And next thing you know, we're incorporating different people involved with caring for that child's growth and development. And as those steps, come together and you start figuring out, okay, what is everything that we have at our disposal to treat a child all the way through, adulthood. And then you realize that, oh, this has a bigger impact on the human being than just the teeth being where they belong. You get to a certain point where you feel really comfortable with how your treatment is going. And then you realize, I can only have an effect on so many people. There's a limit to how many people I can treat in my own office. Mm-hmm. So then, I basically meet up with Lauren, and in teaching through the Invisalign forums, we met and combined, put together a program that is now the Airway Health Solutions model. But the idea there was that there are people all over the country that could benefit from having earlier growth and development treatment related to sleeping and breathing. And since the model really isn't tooth-based, it's foundation-based, it's not something you learn in school. And so if you took my path, well, that's a decade. It took me a decade to get my act together. So once I began learning about this stuff, it was 10 years of putting all the pieces together and one piece at a time. And next thing you know, you're in a position where maybe there's an opportunity to teach other people in other locations so that more patients benefit from this type of opportunity. And that's really where it all comes from, is that I'm limited in who I could treat in my office. But if I could teach other doctors in other locations, now they have the opportunity to share this with their community, and it tends to be, well received. So it's an opportunity for a lot of other patients to be treated, given the fact that I spent a decade kind of putting together what I now know is a very seamless approach to treatment. But why should another doctor spend 10 years getting there, or even 8 or 6, when I might be able to shorten the learning curve? And if I could shorten the learning curve, more people would benefit from that opportunity.
Absolutely. And once you, like we said, take that first step and dive into Airway and whatever course you're going to take, it just opens your eyes, because Airway is everything. And, I kind of giggle inside when I'm speaking with somebody and they tell me that, airway dentistry or airway orthodontics is a fad, because it doesn't even make sense. And I say this, I feel like every episode, because I hear it so much and it makes me like so angry because how can airway be a fad? Like, we have to breathe. And that literally doesn't even make sense, somebody making that kind of comment. And so I know everything you're doing with the course and spreading that awareness to other providers so that you can help them reach more patients. You know, I feel like it's all of our life's mission to just spread this awareness. Where do you see airway orthodontics being in like 5 years?
Well, the 5 years might be a lofty goal, but there are groups, beyond me working at, spreading the word and trying to drive change in dentistry. Because if you think about the difference between the medical and the dental community, the idea is that the medical community doesn't have wonderful options for growth and development at the maxilla and mandible level, which is really where you get your airway space from. How well did your face grow? So the idea is, if the medical community doesn't have answers and they could only treat in the symptom category, well, then it really is up to the dental profession to do it. And if the dental profession remains focused on the teeth, well, then we only have a certain level of success with treating our patients. Now we're tooth fixers. Not that that's a bad thing, but it's limited to the difference you could make in someone's overall health. Now, all of a sudden, if the dental community were to pick up growth and development earlier and get the bone to grow to its full potential, really then what you're talking about is developing a really healthy human being at the end of that. Because if your bone grows fully, you breathe better, you sleep better, now you're a healthy human being. So the idea is, we have a wonderful opportunity. Is 5 years it's a little short. I don't know that it's going to make that kind of change. The dental schools and universities tend to lag a little bit further behind. And I would hope it would be as fast as possible, but maybe it's going to be 5, maybe 10, where that awareness has grown enough that, the general dental community looks at the opportunity to help a patient breathe and sleep better as their, like foundational or principled, driving force of the practice. What can we do to offer our patients an oral cavity that allows for better breathing and better sleeping? Now we're really heading in the right direction. So look, the idea would be this should be the standard of care. The standard of care should be that a human being is an obligate nasal breather, can breathe nasal airflow all the way through the day and night, not have to rely on compensatory mouth breathing. And in order to be a nasal breather through the day and night, you need to have your jaws fully grown. And that's really the dentist's responsibility to get the jaws fully grown. And the idea would be from 3 to 12 or 13. If we miss that window, now we've got to wrestle with that patient a little bit more as an adult. It's not impossible, but the best opportunity is younger versus older. So I'm hoping that this really evolves into being the standard of care, that we look at dentistry as foundation first, teeth second, and that the dental community would address the growth of the foundation primarily, followed by the teeth secondarily. And you get to do both. We're not trying to get rid of the teeth. We would like to have them, but they should be the second priority. The first should be the growth and development of the human being.
Yeah, absolutely. And I love, I think you said it maybe in the interview with Lauren, and I'm sure you say it on a daily basis, that there's no such thing as crowding, that it's underdevelopment of the jaws. I love that.
That's right. That's right. It took me a while, but after a while, it's about perspective. And so I do not see crowding anymore. What I see is underdevelopment. And so I don't treat crowding. I don't see crowding. I don't diagnose crowding. I know it's there, but the crowding of the teeth is not the issue. It's the underdevelopment of the jaws. And so technically a human being doesn't have crowding. What they have is an underdeveloped foundation. The teeth kind of fought for position and they landed where they landed. Underdeveloped jaws lead to crowded teeth. What the patient has is an underdeveloped jaw structure, not crowded teeth. And so when you develop the jaw structure, the crowding goes away. So we treat crowding by growth and development, grow the jaw structure, and alleviate the crowded teeth.
Now let's talk a little bit about the different expansion processes. So the difference, or when I guess you would use, a growth guidance appliance versus like a fixed expander.
Sure. So I'm a big fan of fixed expanders in children, and my starting age is usually about 8 years old. At the age of 8, that's a wonderful time for children to have fixed expanders. And really it can go all the way through the teen years. So the fixed expansion works beautifully from 8 through even 17, 18 years old. The idea is having an appropriate technique based on the maturity of that bone. It's a little different when you're 8 or 9 versus 15 or 16, but all of those age groups, it's appropriate for fixed expansion. Removable works as well. I prefer having the compliance issue taken off the table. So I'm a big fan of fixed expanders. Very rarely do I use a fixed expander below the age of 8. On rare occasion, a 6 or 7-year-old, I would put a fixed expander, but very rare. And the reason is that there are guidance appliances that exist for multiple different places that you can get your hands on. And all of those guidance appliances are very effective from 3 to 8.
Mm-hmm.
So from 3 to 8, we have this wonderful window to redirect the breathing and the musculature so that we can get our growth and development back on track. Most children, it's very visible by 3 or 4 years old that their growth and development is not on track for normal or ideal. And when you're underdeveloped, you can intervene the moment you meet that child. So from 3 to 7, 8 years old, I'm a big fan of removable guidance appliances. And so those appliances are worn and they help with the breathing, they help with the musculature, they help with balance, positioning. And next thing you know, you redirect your growth and development. And then the goal is to have that child who's 3 to 7 get back on track and grow their way out of needing an expander from 8 to 12.
Mm-hmm.
And we go from there. But we don't get to meet every child at 3 or 4 years old. Some of them walk in at 8, 9, and 10.
Mm-hmm.
And that's the age group where we think about fixed expanders because they may be so underdeveloped that their symptoms spill into the medical category versus just crowding of teeth. And then we're thinking about fixed expanders as a way to give them the room for their tongue and to have an effect in the nasal chamber that provides for better airflow and better sleeping and a quicker correction of their so-called medical symptom list that might be related to that poor breathing and sleeping. So the fixed category, 8 to about through the teens, so 16, 17, 18 years old. As soon as you get to that 20-year-old mark and above, well, you're supposed to be a more mature and also responsible human being. I prefer removable expanders. And so for the 20 and above mark, as soon as you're not a teen, I'm a big fan of removable growth and development appliances, expansion appliances, however you want to use the words for them. But I prefer removable because the bone is more mature and I would like that to be a much slower process. And basically, we're just trying to take advantage of the biology that exists at the different ages. And if you have a nice, slow technique that cycles pressure and tension, you can have a wonderful opportunity for growth and development in the maxilla and the mandible at an older age like 20 or above. And so the idea there is removable appliances work beautifully to develop a foundation. And then after that, you address the teeth. So typically the adult, that 20 or above, would go from removable expanders to like a clear aligner to go ahead and finish the job. Foundation first, teeth second.
Now, because it is a slower, process, that's why, because I had a question on here that came in from, I don't even remember if it was a doctor or a patient, but would adult expansion cause periodontal issues?
No, the good news is no. And the idea there is no, provided you have an appropriate technique. And so the idea is if you have a removable expander, it's going to have a mechanism by which you would be turning it. So if the turn is appropriate and the wear time and the cycles of wearing and removing it are appropriate, you can generate some really nice foundational growth through the sutures, which means you're not pushing the teeth through the bone. A removable appliance for adults does not push the teeth through the bone unless the technique is poor and or the turning is aggressive. So all of a sudden, if the turning is aggressive, you're applying more pressure to the teeth. Next thing you know, you might have some recession on your hands. If it's not worn appropriately, well, now the bone remodeling isn't keeping up with the device growing as it's being turned. Next thing you know, again, it boils down to inappropriate force. If you have inappropriate force, you can cause some recession. And that goes across anything, whether you're using braces or removable expanders or fixed expanders. Inappropriate technique, inappropriate force, you can cause your list of damage. And it could be to the gum, like recession. It could be to the roots, like resorption. It could be to the bone loss. So yeah, the opportunity for, let's say, damage or the negative or risk list we would make really comes from poor technique. And the result of that would be poor force as well. We try to avoid that with, a nice teaching course.
Absolutely, which we are going to talk about at the end when Airway Health Solutions next courses are coming up. So in regards to how long the expansion process is, I mean, I guess we should probably break this down in ages, but what I'm
Sure.
thinking that people might be wondering right now, with a traditional RP or rapid palatal expander, you're thinking anywhere between 6 and 9 months that it's going to be in the patient's mouth. So with your fixed expanders, what's that process like?
Sure. So just on those fixed expanders for a child, they're only active for a few weeks at most. In other words, with fixed expanders in a child, even a slow turning rate will deliver the expansion within a few weeks' time. And we maintain that arrangement for a few months. So we might have the expander in for a total of 6 months, and 2 or 3 might have been active. And then there's a little passive while we get our other pieces of the puzzle in place before we're ready to remove it. Removable expansion appliances are going to go much longer because now we're asking for a mature bone to remodel over time, and we have to do a lot of cycles of pressure and tension and have a really nice wear pattern during the day and night. And next thing you know, we think about 9 months as a minimum. But for the full effect, depending upon the patient's diagnosis, it could be up to 15, 18 months. The idea where you would be in there longer, the patient who walks in and has the bilateral posterior crossbite. An upper jaw that is so narrow that both sides have the back teeth in crossbite, you have a long way to go. We think about 15 to 18 months, not to mention that it might even take 2 expanders, one after the next. One might get exhausted. And so if we have that bilateral crossbite and we need to go a certain length, well, the 6 or 8 millimeters that might exhaust the first expander might be in need of replacement for another one to go farther. So sometimes we have to use 2, one after the next. We have patients who can resolve their issues within 6 to 9 months, but they tend to be less involved than a bilateral crossbite, so to speak.
Now, is there any times when you would take the fixed expander out and then have them in some type of, guidance appliance, whatever kind it is, to maintain that expansion?
Oh, yes. So the idea is to get that fixed expander to catch that child up to where they should be and then get rid of it. Because that fixed expander is a wonderful tool to get you where you want to be, but you don't want to have it locked in past that because then it's holding them in a place while you would like them to keep growing.
Right.
So the idea is if we have a 9-year-old and we put a fixed expander in and we give them 10 millimeters to get them where they should be, well, the 9-year-old is a continually growing human being. So once we catch them up where they're supposed to be, then we want to take it out and get the body to continue to grow naturally. That's where we get involved with the OMT, because with the orofacial myofunctional therapy, we need to have that musculature and breathing in order. We need to have proper muscle balance, proper muscle strength, proper muscle function. All of that adds up to better growth and development. So the idea is the expander is going to help you get caught up to where you should be, but you don't need it locked in for an extended period of time to hold something that should be continually growing, going forward and wider. The idea there is to have the pieces of the puzzle in place so that when you take the expanders away from that child, you have the right ingredients and treatment protocols in place to keep that child growing wider and forward. Because the mouth isn't supposed to stop at age 9 or 10, it's supposed to continue to grow. So we want to have that expander in because we like what it can help us do, but we want it out as soon as possible because it's not a continually growing appliance. At some point, it becomes just a fixed retainer. We're not trying to have an extended time in fixed retainers in any child because we don't want to lock them in one place. Right. So yeah, we want to graduate away from those and then let the body's own musculature take it from there.
Absolutely. And what about lower expansion? When are you when are you doing lower palatal expansion?
So the indications for a lower expander, there's only one if you get an upper expander. So if you have an upper expander, you're getting a lower expander. So I only use both. I don't have an example really of using an upper only. And the reason is, if a child comes in and has a significant discrepancy in their width, 3 or 4 or 5 millimeters wider is not a significant difference for them. And that may not even make a difference in the breathing. If we only use an upper expander, it tends to be that you can only expand a little bit. And the reason is, well, if we put an upper expander in and expect to go 10 millimeters wider, the top teeth would be outside of the bottom teeth. That's not a good place to be. If we put an upper expander only in and we're limited to 3 or 4 millimeters, all of a sudden we have the upper lingual cusp getting out to the buccal cusp on the lower. So we're creating a discrepancy in the bite where the top is flirting with, let's say, having a crossbite. Well, if the lower doesn't have movement out, meaning no lower expander, what's going to happen when that upper expander comes off? The inclines of the occlusion on the bottom teeth riding the top are going to force the top right back. So it should be no surprise that there's a fair amount of research that shows if you use an upper expander and you take it away, it goes right back to the beginning where you started. Well, when you look at that research a little more closely, and I think it's 32 papers, there's no less than 32 papers that were written on upper expansion, not necessarily being stable. You put an expander in, you crank it open, you have some width, you take it away. Well, none of those papers address the lower. The lower doesn't get an expander, so now we know there's a limited amount of expansion being done. None of those papers involve myofunctional therapy. The idea is if you give someone an expander, well, the reason they're so underdeveloped, the tongue wasn't doing its job in the first place, so the tongue isn't living in the palate. Give someone an expander, move the palate wider, take the expander away, the tongue is still not living in the palate. Of course, the muscle is going to drive the condition right back to where it was. The inside is weak, the outside is strong, you're going right back to your starting point because that's where the muscle had you in the first place. So the expander is nice to catch you up, but you need the lower because we don't meet children who need 3 and 4 millimeters of expansion. We meet children who need 10 and 15 millimeters of expansion, which means the lower is getting a lower Schwartz appliance. It's fixed. But that appliance goes in and it drives a good 8 to 10 millimeters wider on the lower, which is an uprighting technique. So all of a sudden the lower teeth tip themselves right up to place. So now you get your 10 or 15 millimeters of expansion in both arches. You've got a beautiful home for the tongue. All you need is the therapy to deliver the tongue to that chamber appropriately. And then on top of that, you have a beautiful upright occlusion, which is very stable in and of itself. So once you've got back teeth that are upright and they come together, they tend to hold and lock themselves in better. If you deliver the tongue to the inside of that chamber, you get to keep your results. So I don't have the experience over 17 years of using expanders where the kids collapse back. They maintain the distance we achieve because of a lower expander being used to really give them the 8, 10, 12, 14, 16, whatever the millimeters they needed was, but combine it with the myofunctional therapy. That's the difference.
Now, why, in your opinion, why don't we see lower expansion as like the standard protocol?
That's a really good question. And I'm not sure I know that answer definitively. I could take some guesses, but the idea is, you know, if you're only ever taught an upper expander and that lower expanders don't do much or you can't expand the mandible, that's loosely speaking. I feel like that's a little bit flip. The idea is that lower Schwartz appliances, which are your basic generic expansion appliances, have been around for decades and they're very effective. And so a lower Schwartz appliance is a simple appliance, whether it's removable or fixed. And there are other styles, Lower Williams, you know, other doctors have names for these, but those appliances are very effective. They've been around for decades. The children who are underdeveloped have both upper and lower discrepancies, not just upper. And developing the maxilla alone, well, that's not effective. If you took the maxilla all the way where it was supposed to be, you'd have a mismatch in the two. And if you don't, well, then you're tied to just doing a little bit of expansion on the upper arch, which kind of relapses back to the beginning where the lower jaw is sitting. So I don't know exactly, but maybe it's because it's not taught. If it's not taught, how could you do it?
Yeah, no, that makes total sense. And then we've kind of already briefly touched on, you know, the importance of interdisciplinary collaboration. So, you know, I know we stressed already the importance of myofunctional therapy, which is huge. Having if needed, a very good release provider to release those tethered oral tissues. Do you want to touch a little bit on how tethered oral tissues can play into these expansion cases?
Absolutely. And so that's part of the diagnosis. You know, every single patient gets a Frenum score. And so I used Dr. Irene Marquezan's protocol. And Dr. Irene Marquezan put together a beautiful protocol to make it objective, not subjective, and specifically for tongue tie, so the ankyloglossus issue. But when you go through Dr. Marquezan's protocol, it takes all of 2 to 3 minutes to score a child or adult. You can score anybody, but the idea is you can score them from 0 to 8 as far as what kind of tie do they have. And it's like golf, the lowest score is better. A 0 means that you've gone through a checklist of measurements and that tongue is unrestricted. It has the most freedom it could have. That's a 0. As soon as you start to score and you're getting points, now a score of 3 is an indication that you now have a tongue that has a small level of restriction. 3 and 4, we're talking about mildly restricted. When you get to 5 and 6 on her scale, you have a moderate restriction. 7 and 8 is a severe restriction. So in scoring a child, you now have an objective way to teach a parent that the tongue is restricted. Now, the significance is that we already have a stack of research that shows the orofacial growth and development is limited by a restricted tongue. So limited tongue mobility leads to limited orofacial growth and development, which is a risk factor for sleep disorder breathing and OSA. Those are the words from the papers that are written. So you have this beautiful research out there that shows, yep, if you have a limited mobility of the tongue, you will have limited facial growth and development, which then is the risk factor for sleep disorder breathing and OSA. So the idea behind this is you make a diagnostic record at the beginning to determine, is the tongue restricted? Anybody can put in expanders and move it, okay? That's not very difficult. We can teach anybody, but the moment you've moved it all out, why does it stay there? Why would it stay there? Why wasn't it there in the first place? Well, you didn't have the right muscle balance, strength, and function to grow appropriately. If the tongue has a restriction, well, we went through all of this effort to make the right garage, right? Here we've got this now beautiful garage for the tongue, but what if this car, right? I refer to the tongue as the Ferrari. It's the body's Ferrari. So the tongue is the body's Ferrari. Now, if you have a Ferrari, you build the right size garage for it. You don't try to build a tiny garage and fit your Ferrari in there. You build a really big one. Now, if you build this big garage, but what if the Ferrari was chained to the tree and it can't pull forward? The idea is you have to release it. In other words, anyone can provide the right space, but if the tongue isn't free to take it, you're still going to have that weakness and dysfunction inside that leads to the relapse of all that good work and effort. So you put it out where it belongs. If you don't release that tongue when it is tied, it's very difficult to maintain a result. You would be looking at fixed retainers forever to hold something in a position that really isn't going to be balanced with the musculature. So releasing the tongue becomes a priority in the diagnostics and the consultation process so that the parents learn that this is an issue. Now, we never force anyone to do anything. We're not here to force treatment on people, but the education is important so the parent understands that this is a reason why we're underdeveloped. It will be a reason where we can actually help to solve our problem and make it stable in the future. So we teach them about revision, and releasing a tongue that is tied is a very important part of the educational process. And would we like every parent to do that? Sure. Most of them will do it once we teach them appropriately. So I'm a big fan of diagnostics for lingual frenum protocols, and then educational process through consultation with parents, and then getting them revised, like you mentioned, at the appropriate place, because you need a good referral to do that. You know, it's very common to have too little released.
Yes.
And so, and I understand nobody wants to do too much and harm the child, but it turns out if you haven't really taken, let's say, all of the training you could to learn how much to release, you're more likely to err on the lighter side. And next thing you know, you get it back and it wasn't enough. Mm-hmm. We got to go do a little more. The right release can really make a difference.
I'm always explaining to my patients, you know, you want to make sure you go to the correct provider. You want to make sure it's something that they do literally almost every day and not something that they perform, you know, twice a year, because technically, you know, any doctor or dentist, ENT, whoever will be able to perform it, but you want to make sure that they've had that specialized training in it. It's just so important because too often I see, you know, the child having to have the tongue revised. And then we talk about, you know, timing of release. You know, we want them to go through that expansion so that they learn the correct placement with the tongue, and the tongue doesn't heal to that narrow arch. And then now we have this big arch, and then they have to have it revised again. So timing is perfect. And I love the whole Ferrari garage comparison. That was fantastic. A couple questions that I have that came directly from patients. We have, are there spaces created in the teeth during adult expansion?
during adult expansion. So let's think about our adults who come in underdeveloped. Now, there's a fair chance they're going to have some crowded teeth. And so if you have crowding, well, as you grow the foundation, it starts to alleviate, the crowding you would have. So you might have a little less crowding than you started with when you grow that foundation. But most of that change is sutural. And so as you're doing a removable expansion technique with adults, you get very little extra space. There's a difference if you're talking about people who have no crowding and may have had teeth extracted. So let's talk about that. If you had 4 bicuspids taken out and your wisdom teeth are gone, well, now you only have 24 out of 32 teeth. Well, you have 24 out of 32 teeth, the next thing you know, that's a significant lack of tooth structure. Now, if you start growing that foundation, you might get some spaces. And so we deal with those spaces because it doesn't change the process. It's still foundation first, teeth second. So we have pretty much every category covered up to this point, meaning we have our cases where we have grown that foundation out fully and given back those missing teeth with implants and or bridge work. We have cases where we've given back 1, 2, 3, or 4 of those premolars that were either removed or congenitally missing. We have cases where we grow and we have, let's say, thinner or smaller or undersized lateral incisors. We might do some bonding or a couple of veneers for people like that. So from a little bonding in some areas to beautiful veneers to replacing a full missing tooth or more, I've seen all of those categories. And some of it depends upon the patient's diagnosis. How severe are their conditions related to sleeping and breathing? Because ultimately you're trying to give the tongue the right amount of room. If the tongue could have the right amount of room, you would have a different human being on your hands. So the idea is, how much room does the tongue need? Well, it needs all of it, first of all. The tongue is the primary cause of all of our trouble. It's the space for the tongue. So when you're thinking about nose versus tongue, the tongue is 90% of our problem, the nose is 10% of our problem. So if we can give the tongue its full chamber back, we're going to be in great shape. And if we have enough teeth, crowding goes away. If we have less than enough teeth, we might get some spaces where teeth once were. Then we figure out how far are we going to go with that? Are we going to do a little bit of that space opening and put some bonding on there? Or are we going to go all the way and deliver a full tooth in those chambers? So we think about their medical history, we think about how severe their symptoms are, and what are we trying to solve? We tend not to stop treating until the symptom list is gone.
Mm-hmm. Absolutely. And again, for the time that you might have those few spaces between the teeth, I mean, it's totally worth it compared to the lifelong, the increase in quality life that you're getting from going through this process. I mean, it's truly life-changing.
Yeah. A simple principle is that, spaces are not unhealthy.
Right.
Crowding can be unhealthy because crowding comes with a smaller foundation, comes with lack of tongue space, comes with poor breathing. Crowding is unhealthy. Spacing is not unhealthy. No one's going to get sick because they have some space between their teeth. So we don't want to look at it. I get it. It becomes a cosmetic issue. But
right.
In dentistry, who's better at doing beautiful cosmetic work than the general dentist? And so no general dentist should be threatened by a little space. We do that routinely. We take care of spaces when people walk in with them. What's the difference if we create a little bit growing and developing, creating the healthy human being? Then we get to fill in some spaces with a little composite or veneer. But even there, it's the smallest percentage of outcome of anything. We don't get spaces in every case. It's rare to get spaces. Usually it's the patient with 24 teeth. The 4 bicuspids are missing and the 4 wisdom teeth are missing. Now you want to develop that foundation, you're going to have that patient get some spaces. But most of the time, there are no residual spacing. It's more about having crowding disappear.
Mm-hmm. Absolutely. That makes total sense. What is the oldest patient you've treated?
So we have treated into the 60s with removable expansion appliances. So that's a nice opportunity. I have gone into the 80s with clear aligners. And clear aligners are very capable at dentoalveolar change. And so you can make a lot of improvements in someone's overall health all the way into their 80s, even with just clear aligners, but 60s for removable.
Now, what kind of expansion would you be getting from the clear aligners?
Well, the clear aligners is tooth and its surrounding bone. So dentoalveolar, the fancy word for the teeth and the tract of bone they're in. Clear aligners aren't going to give you sutural changes, but clear aligners do deliver dentoalveolar change. Clear aligners are a removable orthodontic technique. And so the idea there is whenever you have a removable orthodontic technique, you have a kinder, gentler process because you have cycles of pressure and tension. When you wear your aligners, they apply pressure to the teeth, but when you remove them, you get the opposite effect because the teeth like to relapse. When you take your aligners out, the teeth like to shift back. So any amount of time that an aligner is out of the mouth, you get that little bit of relapse. It reverses the pressure and tension cycle. So when your aligners are in, there's a push on the teeth, but when your aligners are out, there's a relaxation or recovery. Any removable appliance can give you bone growth. And so we have a wonderful opportunity at using any removable technique in an adult to deliver bone growth, because removable orthodontic techniques do not cause damage because you're cycling pressure and tension. Whereas fixed orthodontic techniques like brackets and wires, and I do use those a fair amount. So I'm a fan of braces when used appropriately, but fixed bracket and wire, it's a constant pressure in the direction you're going. And so you don't get any relief because the wires are constantly attached. You're only changing the wire once every so many weeks and it's only out for a minute. So basically with fixed orthodontics, you have a constant pressure on one side of the tooth and a constant tension on the other. You can have your share of recession, root resorption, fenestration, dehiscence. We have fancy words for damage. So we worry about fixed for the entirety of the case, whereas removable is a little healthier.
Mm-hmm. Absolutely. And then one last question I'm going to ask, and then we'll have Lauren come back on because I see the questions popping up at the bottom of the screen. So somebody, okay. So they must have saw the before and after pictures in one of the other talks that you guys did, and how we get rid of that high arched palate, and how we get it to, well, I'm just
Sure.
gonna have
Yeah, sure. Well, that vault's going to rotate back down with expansion. And so if you have a child, basically a child is going to get a fixed expander, and with that expansion is going to come widening and then a dropping of the vault. That's how the body is narrow and vaulted. They go hand in hand. Mm-hmm. So when the body is nice and narrow, the vault is nice and high. So we're narrow and vaulted. You give the expander and you get this. So the idea is in a child, it's a fixed technique. In an adult, it's removable. But the removable appliance gets adjusted, and that acrylic that's in the palate gets removed each month. There's a little bit of a layer taken away. We're taking away that palatal vault acrylic over time so that the vault has a chance to rotate down. If we keep the palatal vault acrylic up there, it's applying pressure in the center. You're fighting yourself because now the appliance is trying to make wider, and that's trying to rotate down. But if your appliance is hitting the roof of the mouth, you're working against yourself. So one of the techniques that has to be in place is a removal of the palatal vault tissue, vault acrylic, so that as we get the acrylic away, that vault can rotate down towards the palate. Now, it's not just the expanders that do it. The tongue is really what shapes it. Mm-hmm. So when you get your expansion appliances and you begin the process of remodeling normal anatomy, it's the myofunctional therapy that gets the tongue in the palate, because the palate is supposed to be shaped like the tongue. Mm-hmm. The palate should be an imprint of the tongue from all of that good compressive and vacuum-like swallow that we need. So your tongue is really the ultimate architect and scaffolding that shapes that vault. So the expander gets you started in the right direction. It's like pushing it in the right direction. Your tongue delivers the final shape of the vault. The better the myofunctional therapy, the better the patient does those exercises, the more beautiful that vault will look.
Absolutely, 100%. Okay, Lauren, if you want to hop back on, we can go over the questions at the bottom.
Okay, terrific. Well, thank you both. Thank you, Brittany. I know it's great to spread this word through the myofunctional therapists, the oromyologists. So thank you for being an Airway ambassador as well. We do have a couple of questions, Dr. Miraglia. When is myofunctional therapy to be initiated? Before and during expansion, maybe even after? So I don't know, you can both answer this, but why don't you start with Dr. Miraglia?
Yeah, so there's no wrong time, but the sooner the better. And so meeting the myofunctional therapist at the beginning is the best, because here you have a child, no matter what age you meet them, the muscle is weak, dysfunctional, imbalanced, it's all wrong. And so here we are, we're going to start on a pathway of growing and developing them. So the sooner they meet the orofacial myofunctional therapist, the better. Now, yep, expanders can get in the way of the exercises and things like that, but they're temporary. And so the idea is, even if we begin and have some exercises that we can do well, when the expander comes out, we really want to be up and running. So I like the child to meet the myofunctional therapist at the beginning, and then having a good relationship, they understand that, yeah, we're going to be using some expanders here. We might be using some guidance. If they know what's coming, then they can help you along the way to make sure they piece together, and you're basically coordinating treatment throughout, especially when the frenum is going to be revised, because now you need really nice therapy before that and after it. And then of course, there may be other things that are involved with this whole, treatment process where timing is a factor, but the sooner the better.
I couldn't agree more. Literally, like, I want to type out everything you just said, put it on a card and hand it to everybody.
Yeah, there you go.
We can play it back and do that for you.
Yeah, and it didn't come up yet, but the question should come up, who gets myofunctional therapy? Everybody, because if I'm treating them, it's because they're underdeveloped, but they're underdeveloped because of muscle imbalance and weakness. So the soft tissue dysfunction, the fancy words are soft tissue dysfunction. Muscle dysfunction is the reason that I'm now treating the child. I'm not correcting the soft tissue dysfunction with expanders and braces and guides and things like that. I need the therapy. And so that comes from the myofunctional therapist. So I do very little of that in my office because I have referrals near me. And so with people like Brittany and others that are around, I can send the patient. It's a referral. If you're in an area where maybe you don't have a referral near you, then you have to consider maybe we need to find our team member that wants to learn and bring it into the office, because every patient that is underdeveloped really does need myofunctional therapy to help correct that. It becomes a piece of the treatment for all of the patients that we're diagnosing with underdevelopment.
And the great news is Brittany's now part of our team with Airway Health Solutions, and she actually helps to provide telehealth services for all of our Airway Health Solutions graduates. So
it's totally doable, everybody, as long as you have a good internet connection, you're sitting in a well-lit room, you have the camera up close to your face, we're going to get really close to each other. It works out perfectly. And, again, what Dr. Miraglia said, sometimes providers will say, well, just let me know who to refer to you. And I'm like, oh boy, literally everybody.
everybody, right?
Just about everybody. And every age. There's this other notion out there that I didn't realize that at first either, because it took me a while to get rolling. Admittedly, there was a time where I didn't know what oral facial myofunctional therapy was. There was a time I didn't know it existed. There was a time I didn't know the first thing about it. So when you go back and then you start learning more and more and more, next thing you know, then you recognize, oh my goodness, this happens to be the first. And if you could choose one, if I had a child that could have one thing done, I'd say you go for myofunctional therapy, because it would be the most important piece of the puzzle. But it's not just for kids, it's for teens and adults also. When you have muscle dysfunction, it can be addressed at any age. And so just like you can go to the gym and work a muscle group or multiple muscle groups at any age with a trainer, you can work on the entire head and neck with an oral facial myofunctional therapist at any age. And there's even fantastic research that shows in adults with OSA, myofunctional therapy makes a difference. It can improve those patients. So you have wonderful research out there showing that oral facial myofunctional therapy for adults with OSA makes a difference, even if it's the only thing they get. So you can improve your breathing just through educating, balancing, and strengthening the muscles that are involved.
Yeah, I just completed a case with a 74-year-old. Was one of my favorite patients. Man, was he compliant. It was great.
There you go.
Yeah, never too old. Absolutely not. And it's funny too, because every time I have a child in the chair, I see the parent out of the corner of my eye starting to do things with and they're like, wait, I think I have that. And I'm like, all right, we'll examine you next.
Yes, you do. That's right. You do.
Yeah. We actually have a patient who's watching, and she had a question. She just started her palate expander, but something that has been brought up is considering MMA surgery. Is it necessary to have surgery, or can I achieve the same result with expanders?
It's so difficult to answer without having all of that patient's records. But as far as MMA surgery, maxillomandibular advancement surgery, in the last 5 years, I've had 2 people do that. And they both were in the severe OSA category. So 2 young people, and young, I mean 25 and 45. Young with severe OSA, and when we pulled all of their records and all of their information, we were looking at that sleep study, which was horrendous, the list of medical issues related to it, the medications that were being taken, and the compromise to their health at the time. And then we look at, well, at that age, for me to get involved with the Frenum release, the myofunctional therapy, the removable expanders, the sequence of events to grow as much as we could, we're talking about 18 to 20 months. Meanwhile, we already have a very severely compromised medical history. 2 people in the last 5 years, both in the severe OSA category, chose the MMA surgery. Now, MMA, the full maxillomandibular advancement surgery, comes with pre-treatment in the orthopedic orthodontic category. So we set up a little bit, then the surgery to bring it forward, then we finish the job. So everything's wider and forward from the beginning orthopedic round to the final orthodontic round with the surgery in between. But meanwhile, with a short start to get them set up for surgery, we send them to the surgeon, and 6 hours later, they go from having a very tiny, like I like to say, the coffee stirring straw. Everyone who's ever stirred coffee with a straw knows the size of that little straw. That's the size of the tube they're breathing through. Now, 6 hours later, they come out with a garden hose. Dr. Bill Hang taught me that word, garden hose. A garden hose to breathe through. Now, those 2 patients have absolutely no OSA diagnosis. They lose their medical symptoms, they lose their medications, the blood pressure, everything goes away. Next thing you know, a few months later, your cardiologist is telling you you're not going to take heart medication for the rest of your life. And you have that kind of difference in a short time, 6 hours, that surgery. So I have 2 patients have done that, and that's it's a very effective surgery. You just have to have the right surgeon. Now, I've worked with 2 groups, both did an amazing job, but both knew how far to go. In other words, going forward a little bit, well, maybe you're going to go from severe to mild OSA. That's not enough. If you're going into a surgery, go all the way. The surgery groups I worked with both knew to go all the way out. You're going to make a big change, but then you don't have an OSA diagnosis and you don't have blood pressure medication and you don't wake in the middle of the night anymore. Your entire symptom list goes away. So those 2 patients who chose in the right surgical care got the full result, and it was beautiful for them. They would do it again. That's how good it was for them. But when you're in the moderate to mild, it's very hard to justify that type of surgery. You want to make sure you're doing it for the right reason. So we don't have a lot of those conversations. It's in the severe category. Mild to moderate, you can make a big difference, but you have to address everything from the nostril through the maxilla and mandible. And so the Frenum revisions, the ENT visits, the deviated septum correction, turbinate reduction, hyperplastic tissue, like all the things that can be done to make better breathing and sleeping get done to that patient. So hard to say, with that patient, we don't know the full list of records, but when MMA comes up, you have to think about maybe they are very severe with the OSA, and then it's not a bad idea to consider, because a consultation is never wrong. You can always learn more by sitting down and talking about what are my diagnostics and what are my opportunities, and then you choose, is surgery for me or not? And if it's not, we go next level. Well, if we're not doing surgery, we talk about removable expanders. If the adult across the table in consultation knows that they can't wear a removable expander, it doesn't fit their lifestyle, they're not willing to, put in that time and effort that it takes to do that process, well, guess what? We don't send them home with nothing. We go back to removable. Now we're going to use clear aligners. So we're still in the removable category. Clear aligners are your next option because that change will make an improvement. And, the quick example are the patients who come to mind who were just in recently. We had a gentleman who could not wear a removable expander. He speaks on the phone 8 hours a day. He said, I can't talk with that in my mouth. I'll do the clear aligners. Well, he began his clear aligner therapy with an AHI of 37. And when he was done with his clear aligner therapy, it's now 7. So 37 to 7. Now 7 is still the mild category, but he went from 37 to 7. No change in diet, no change in exercise, no other significant change. So 12 months of clear aligner therapy moved the teeth away from the tongue. Now he doesn't have crowding anymore. His teeth are no longer crowded. And when you move the teeth away from the tongue and the tongue has more room, and the tongue was your primary source of airflow issue, you can go from 37 to 7 with just clear aligners alone. So you're working your way down the list. It sounds like that patient maybe should pursue more diagnostics and information and then figure out what is the right thing or next step or what are my options.
I wanted to add one thing to that, Lauren. Dr. Miraglia, when you were talking about making sure you're finding the right providers, ENTs are also in that because,
Yes.
not every ENT is, you think all ENTs are airway focused, but they're not. So you do want to make sure that you choose a good ENT as well to truly assess, just like Dr. Miraglia said, everything, septums, turbinates, everything. It's not just, let's take a peek at the back of your throat.
Yes, and some of them are further down the road. So you have ENTs who are paying attention to breathing and sleeping. And then some aren't. And so again, you can get a consult with one and they'll look and say you're okay. And you can go to another where they'll make the full list from the nostril down to the vocal cord. Here's why your air's not flowing well. And then next thing you know, you have a scope and a report that shows every little detail from the nostril to the vocal cord where your air would get interrupted, and then what are the choices to make an improvement. Yep, both of those are available, and the idea is to find the right one to get the right opinion on, so you could make a difference for your patient.
What do you tell your adult patients who were told by other doctors that they could not be expanded with removable appliances?
Yeah, well, we're happy they found us, because now I have an opportunity to treat them. And so at the beginning, we have to just sit down and teach and educate. And, luckily for me, 17 years later, I have a lot of photos. I can show them adult after adult. I can pick out pretty much any decade and show them, oh, well, let's see, since you're 58 years old, let me just show you another 50-year-old. Here we go. Here's the before and the after, and here's what we used. And then they can see it. And so I say, oh, wow. Now, that does happen sometimes where maybe you weren't given all your choices, and sometimes there may be a good reason for that. There may not be a good reason for that. But the idea is, while we're using it nicely and having wonderful results, it doesn't mean that everybody either believes in it or has done it or tried it. But the idea is that it's not appropriate to tell someone they can't be expanded when the maxilla is a dynamic bone. And so the maxilla allows adjustment for the first 6 to 7 decades of life. And so we have an opportunity in a slow and methodical pattern to grow that maxilla and to help a patient breathe better and to have a better foundation and better bite in the whole list. So we have these patients come in. I see them regularly because they come in and they tell me where they've been or, what they were told, jaw surgery only. I get all of those comments. As time goes by and they see their progress, because we take the photos, we take the measurements, we can show them how much different they are thanks to that removable expander. Usually someone will make the comment, too bad it doesn't work, or if it's been done before, it's probably possible. I've heard that a couple of times too. If it's been done before, it's probably possible. So, in the end, we make a tiny little joke about it. Happy you made it here. Glad we could help you. And yeah, it's totally possible. We do it on a regular basis. We don't, just pick a patient here or there. We do it for everybody that would need it. It's an option to discuss. Whether they choose it or not is different. But we teach all the patients about underdevelopment and then their choices.
Okay, if upper and lower expanders are used in combination with myofunctional therapy and teeth are uprighted, are aligners, teeth are righted, are aligners even necessary upon removal?
Well, when we're using upper and lower, when we're using removable expanders, we're growing the foundation. So when you grow the foundation, you're pretty much going to need some sort of coordination of the teeth at the end. In other words, I don't have an example of using removable expansion appliances in an adult and the teeth then are perfect at the end. Typically, their teeth are not perfect at the beginning. With the removable expansion appliances, we develop the foundation first, and then we address the teeth second. So all of the patients we put into removable expanders know that we're going to follow this with clear aligners. So we go from removable expanders to develop the foundation, clear aligners to then coordinate those teeth and have them connect perfectly. But the clear aligner technique that follows the expanders is still a wider and forward technique. Everything that's done with the clear aligners is the same direction the expanders were going. Expanders are meant to deliver wider and forward. Myofunctional therapy helps deliver wider and forward. Appliances, whether they're clear aligners or anything other, they should be delivering a wider and forward pathway or technique to continue the process. So we're still in the same direction, but it's always needed. in my world.
Great. And I have one last question. Should expansion precede tongue tie revision or release? Like, what order does that go in? I guess that's the question.
Sure. Well, because they're all being done in a similar time frame, there's no right or wrong way to do it. If we met a child and we felt like, oh, look at this, we scored this child at 6 or 7 on Dr. Marquezon's score. That's a really restricted tongue. Let's get that child over to Brittany. Okay, begin the process, get the release, do more. We'll get your expanders a few months from now, because that would be severe, 6, 7, 8. If you come in and you score a 3 or a 4, but you can't breathe and you can't sleep, I might want to get those expanders in there and open up that nasal chamber and get some airflow. And then I might get that child over to Brittany to begin the process, because now I know within a few months, I want to get that expander out to revise and move that tongue into the palate. So whether it's first, second, or third, we're talking about a matter of a few months. It's not like something's going to be next year or a year after. So I don't know that there's a wrong time to do it. You just need to do it. So we want that child having revisions with myofunctional therapy, whether you did it first or second, in a tight time frame. You're checking the list of things that child will need to do. Brittany, you can add to that too.
Yeah, no, I agree with that. And I think a lot, like everything, it's all case specific. It kind of depends exactly, like Dr. Miraglia said, what's going on with them. What are their other symptoms?
Sure.
Okay, I know, Brittany, you're a busy lady. You have a course to teach at 8 o'clock on the top of the hour, but I do have a couple more questions. So I know you're going to sign off so you can prepare. There's a lot we can do in 4 minutes. So thank you for, again, bringing this to everyone's attention and for doing such a great job. And we look forward to hearing your podcast. I'll show your information at the end so people know where to contact you.
Okay, thank you, everybody. It was so nice. Well, not seeing you all, but seeing you, Dr. Miraglia, for sure, and listening to you all. Okay, everybody, have a good night. Bye.
Thanks, Brittany.
Thank you.
So, Dr. Miraglia, I have a question from our good friend, Dr. Frith. If expansion with clear aligners only, is there any improvement in the nose space?
Well, the aligner isn't going to make improvement in the nose space, but we still address the nose. And so adults who get clear aligners to deliver more tongue space, we still evaluate the frenum. We still offer myofunctional therapy, because anytime you can get your tongue into your palate, it will help to shape, what you're doing. But the nose, the ENT gets in the nose. So we still send that adult to the ENT for a scope, because I don't know what's in there. I want a report back from the ENT, and I'd like to know about all of that tissue from the nostril to the vocal cord. So we get a report back that tells us about the turbinates and the concha and the septum and the adenoids and the tonsils and what's in there. And typically we find stuff in there. The less the nose is used, the more it closes off. So when we get a report back from the ENT, well, immediately we start talking about hygiene. Well, let's start blowing our nose using nasal sprays, maybe breathe right strips at night. There's a big difference right there in airflow. Then we start talking about that deviated septum, what an improvement that would make if we corrected that. What if you have hyperplastic tissue in there? A lot of adults, it's been such a long-standing condition, they end up with little polyp formation in their nose, and laser techniques can remove this stuff. So the nose gets attended to usually through the ENT. You just need someone who's willing to look at those obstacles as airflow restrictors and then wanting to get involved with opening that up. The best news that you have is coordinated together. When you give the tongue more room by widening and opening up the arch, you now have the ability to breathe through your nose. If you have that collapsed mouth and the ENT does all that nose work, they still have trouble breathing through their nose because the air can't get past their tongue. So you do want to develop the oral cavity so the air can actually get past the tongue. Otherwise, you still compensate with mouth breathing. All of the work on the nose, we need the patient to be a nose breather when it's done. And that really is secured by delivering tongue space. Give the tongue back its room, good things happen to the human being.
Absolutely. I'm going to just share some information that I know people wanted to have contact information and your upcoming mini residency. So let me go ahead and do that. And I know this is our kind of our baby together, but why don't you share a little bit about what doctors should expect leaving the course for the pediatric day and the adult day once they're completed?
Oh, sure. So, this is a technique course. We spend a full day teaching how you treat the child. And so from the age of 3 through the teen years. Basically, that pediatric day is to learn the full diagnostics that are needed in order to have a nice consultation with the parents to discuss the options for treatment, and then delivering the treatment with technique specific, appliances, and how do you go about getting that child, grown fully to resolve their underdevelopment as well as the symptoms that come with it. So a full technique day to learn how you treat those children. You walk out of that course able to treat children. The adult is a similar pattern. The full diagnostics so that we could have a nice thorough consultation process so the adult knows their choices for treatment. And once you know your choices for treatment, it'd be nice to know how to deliver it. And so we teach everything from the removable expansion appliances all the way through the clear aligner technique that will deliver a larger oral cavity for that tongue to live in.
Great. And I encourage everyone to watch the webinar that we have on our website. It's listed there. It's www.airwayhealthsolutions.com/webinar. So you get a good idea of the history of malocclusion, sleep disorder breathing, and Dr. Miraglia features some really wonderful cases, 3 cases with different scenarios. So take a look at that. And I'm also in expansion therapy myself with Dr. Miraglia, so I have some YouTube videos. We have a new YouTube channel with Airway Health Solutions, so please look for us and subscribe. I'm just starting our Airway chats where I have Dr. Miraglia and I have Kevin Ohlendorf. I'm looking forward to Dr. Liao coming on board and Dr. Scott Siegel, so we're really excited to spread the word as much as we can. And follow me on my blog. Very patient-friendly videos, so you can use them for patient education. So tune into that and hope you follow me on my blog. And then lastly, a lot of people wanted to know what fixed and removable appliances you use. So we always co-sponsor with Kevin Ohlendorf. I know a lot of his clients are watching tonight, so I wanted to maybe you want to talk a little bit about Kevin's appliances real quick.
Oh, yeah. I met Kevin a long time ago, and probably for now a decade I've been using his appliances. His laboratory is fabulous, and he makes wonderful removable and fixed style expansion appliances. I pretty much exclusively use him now, and so I've had a wonderful amount of success sending him, records so that he could build, whether I'm asking for removable or fixed appliances that usually drop in very comfortably and deliver, the results that we're looking to get. So I'm a very happy user of the Ohlendorf laboratory appliances. Great stuff.
And he's a nice guy too, right?
Oh yeah, totally. Great guy.
Okay, and then here's Brittany's contact. Brittany's our newest member for Airway Health Solutions. So she's available for telehealth services. She's located in Connecticut for the local folk here. So check Brittany out. Here's her contact information as well as her podcast, I Spy with My Myo Eye. She has some great guests on. So tune into that to learn as much as you can on this airway rabbit hole, so to speak. Well, I think that sums it up. We're at the top of the hour here. I wanted to thank everyone for their time. Dr. Miraglia, thank you as always for sharing your insights and really helping to help doctors help their patients breathe, sleep, and thrive. Any closing remarks?
Oh, no, my pleasure. Thank you very much. And thank you everyone for your time and attention. Appreciate that.
Okay, have a great night, everyone. We'll see you soon.
Good night.
Bye-bye.